a total, or we performed a total of 824,686 tests. If we look at Baptist Memphis, we've tested 70,194 people for a total positivity rate of 10.7%. And system-wide, we've tested 465,516 people with 17.05% positivity. If we look at variant testing so far, we have done 502 variant testings of late. 378 of those were Delta variant, 42 Alpha variant, and 2 so far in the system have been Gamma variants, not in the Memphis area per se. So as usual, just I'll point out that we don't necessarily do as much variant sequencing because it is an extra test. It doesn't change what you do for an individual patient with the infection, and frankly, so many are now Delta variant. Almost all are, so we don't routinely do as much of that testing as we did before. If we look at the hospitalized people at the moment, at Baptist Memphis, we have 96 people with COVID in acute care non-ICU beds. That's 96, and we have 42 people in the intensive care units with COVID-19 for a total of 138. That's actually down slightly. We have peaked at 152 during this latest run with Delta and have been down for a few days now, which is encouraging. Of those 42 people in the ICU, 35 of those 42 are on the ventilators. And so that is its own concerning point because a lot of people are in the ICU and a lot of those are on ventilators, a little bit higher than what we probably saw in our last peak. If we look at Baptist DeSoto, there are 92 people in acute care non-ICU beds with COVID-19, and there are 18 people in the intensive care units for a total of 110, which is quite high. 15 of those 18 people in the ICU remain on the ventilators there. So of the vaccinated data, if we look at the 60 people, if we look at 10 recently admitted, fully vaccinated, let me back up, of 20 new admits, only 2 were fully vaccinated. So we continue to see a very high rate of people who were unvaccinated, both coming to the hospital, and an even higher rate of those who are in the intensive care units and the deaths. They essentially are all unvaccinated people. We have anywhere from 5 to 10%, depending on the circumstances, and they typically are people either who are immunosuppressed and might not be expected to have gotten a good response from the vaccine in the first place, which is obviously well demonstrated on a number of levels. And then occasionally we'll see people in an elderly age group, 80s or higher, who will have some breakthroughs, though even they tend to do significantly better. So happy to answer any questions if there are any.
Hey, Dr. Threlkeld, it's Corinne. How are you today?
Okay, Corinne, how are you doing?
I'm doing all right. Hanging in. So I had a question from a reader who wanted to know if you had used or had any success using fluvoxamine as a COVID-19 treatment.
So it's a very good question, and I have not personally used it yet. I mean, for the reason that we really don't have enough information, I think, to adopt it in any meaningful use right now. It is one of the very interesting things under study now. I've kind of used fluvoxamine as an illustration of how you go about doing proper trials. And if you look at the Together trial, which is a study, and actually was referred to in a 60 Minutes study, a 60 Minutes piece a few weeks ago about the drug. It is a not widely used antidepressant anymore, mostly shelved, but it's one of the many common inexpensive medications that have been looked at in the same way that hydroxychloroquine, ivermectin have, to test, to see if we could repurpose some of those medications if they would have any activity against coronavirus. And so it turns out that unlike hydroxychloroquine and unlike ivermectin, which failed roundly in that Together trial, the Together trial being a very nicely organized group of randomized, blinded, controlled clinical trials that really give you that unbiased look. The researchers don't know whether it's placebo or the drug. The patients don't know whether it's the placebo or the drug. So those trials remove a lot of the bias that can creep into these sorts of tests. And so when you look at that, fluvoxamine actually passed reasonably well through that first hurdle in that trial. Not a huge trial, but it really showed, I think, 20-25% improvement level, if I remember correctly. And so it is appropriately moving on to additional larger and again well-controlled trials to find out exactly how it will perform. It seemed to do reasonably well in that trial. It seemed to be very well tolerated as well. So I think the preliminary information is that it would be promising. I think we're well short of having enough information to push ahead and try to use it with any sort of large amount. I mean, I realize much as we have seen throughout this pandemic, there's been the feeling of, well, let's don't just stand there, do something. And so that really crept into hydroxychloroquine. It certainly has been the case in ivermectin, for which there are no meaningful data. What data there were had been retracted with all manner of problems of the research. But fluvoxamine absolutely is one that is very interesting and is being looked at, I think, in additional trials. So I haven't used it yet for that reason. I think we need more information to really prove that it is truly effective and it's truly safe at a dose that is effective. We really haven't done those sorts of studies yet.
And one other question I had for you about breakthrough cases. So should people who have been vaccinated and are exposed to the virus or start feeling a little under the weather be looking for specific symptoms? I guess, are breakthrough cases, do they have different symptoms than people who are unvaccinated and get COVID-19?
Yeah, so another very good question. I think a lot of people have looked at that. I think for the basic situation is that people should not try to pick and choose what symptoms they're having because there's a tremendous amount of variation there. It varies with age, it varies with underlying medical problems. There are just so many variables that I think it's very difficult to say if you've been a vaccinated person, your breakthrough is going to be different in way X, Y, or Z. So I think it's very clear, obviously, that there are breakthrough cases. We said from the beginning of the arrival of the Delta variant in our city, before we had the CDC data, before we had any sort of really well collated and researched data, we said, you know what, we've seen more breakthrough cases in people who have been infected before and vaccinated already with this Delta surge than what we have seen collectively before the 2 weeks or so when it started. So it clearly was a phenomenon that we were seeing. And that, of course, as expected, bore out when people looked at it in larger amounts. But I think the main thing is to know the spectrum of the illness and if you've been exposed to someone with COVID-19, vaccinated or not, previously infected or not, you need to be careful because we know that despite those protections, you can still get it, particularly minimally symptomatically, and you can then spread it to other people. So anything with nasal stuffiness, sore throat, malaise, feeling tired, just bad in general, achiness, diarrhea, nausea, it really throws a whole spectrum of symptoms at people. And in this moment in time, you need to be very careful to look at those things. And I can't tell you how many times people call me and say, I have a little bit of a sore throat, but I'm fine. And I'll say, go get tested. And they go get tested and they're positive. And so it's very common right now. So I think the important thing is not to feel overconfident that you're going to be protected from any infection. Now, again, natural immunity in a lot of ways, and certainly vaccination as well, does a great job of protecting us against severe infection, hospitalization, and death. But these new variants have some increasing resistance, and they just aren't as good at preventing mild infections per se. And the other thing, just as a spinoff, and I won't belabor this, but one of the real problems out there is people want to go measure their antibodies, and they say, okay, I'm good. I don't need a booster, or I don't need to protect myself by behaviors. We don't have any idea that the antibody level that you're testing has anything to do with protection. it is measuring a value that we have no idea what it means. So do not go out and get an antibody test and decide that you're okay because you have more than your next door neighbor of antibody levels. We just don't know how that correlates with protection. And it's probably the single largest, well, one of them anyway, one of the largest mistakes that people are making right now. They want to measure something, and they're measuring something that we really can't use to predict the answer that they're trying to derive from it. And it's just sort of a garbage in, garbage out sort of thing. You can't know whether you're protected right now based on your antibody level, with the possible exception, the fact that if you're immunosuppressed, we will sometimes test people and show that if you have no antibody after a month or more, 3 or 4 weeks after a vaccination, then that would suggest that you really don't have anything going on and you need to be extra careful to protect yourself, because you are, in that sense, you probably need to behave as if you were functionally unvaccinated.
Dr. Threlkeld, could you talk about the recent study about natural immunity versus vaccination?
The Israeli study, is that what you're talking about, asking about, Jane?
Yeah, it's the number one bullet underneath today's meeting notice.
Yeah, so a very interesting study that is, I think, encouraging in a lot of ways. It generates a lot of additional questions that have to be looked at. And unfortunately, it's generating a lot of, I think, improper conclusions that is leading to some potentially dangerous behaviors. And so what that study really did is it looked at people who had gotten natural infection in one arm. The second arm was people who had been vaccinated. And then the third arm was people that had gotten natural infection and been vaccinated again on top of that with one vaccine. So those were really the groups. And they found out that if they and then they looked at different time points. So it's a fairly complex study to sort of describe in detail. But if they went back to the January, February time frame of this year for people who have gotten infected or vaccinated for that matter, and then they looked at them during the months of kind of June, July, and part of August of this year to see if they developed infections or significant symptomatic infections or hospitalizations. And they looked at all those things to see which group was the most protected. Now, that time frame where they followed it up in June, July, and part of August is significant because that's kind of when Delta virus variant was predominant in Israel. So we really are looking at old vaccines, old infections, Wuhan or Alpha, and how those things protect against the Delta variant. And it turns out that the people who had demonstrated infections by PCR previously really had a pretty good clinical protection, superior to that of vaccination alone, which is, you know, it's funny. It's not surprising at all because natural immunity frequently is outstanding. But there's some test tube studies that suggest maybe that the antibodies that you get from the vaccine are actually a bit superior in quality and breadth of activity from what you get from natural infections. So there are a lot of competing pieces of information there, but this is a real world study with all the advantages and potential disadvantages of that. So they did show, I think in a very encouraging fashion, that natural immunity was pretty protective against the more severe aspects of the disease, and in fact was more likely to protect you from a positive test and from infection and even serious infection than was vaccination alone. Now, the kicker is there that the best way to protect yourself is to have had the infection and then to have at least a vaccine on top of it. So one important take-home point is that this study does not contradict some of the other more recent studies that came out of Kentucky from the CDC that pointed out that even if you've been infected before, you can increase your protection by more than twofold by going out and getting a vaccine on top of that old infection. So there's nothing in this study that contradicts that whatsoever. It does also say that an vaccination on top of infection is more helpful. Now, there are a couple of things, and I don't want to just belabor the points, but there are some potential problems with this study. Number one, it's like many of these studies, just in a preprint situation right now. It's not been reviewed by experts in the field to be reviewed for full publication. That has to happen because there's some things they have to take into account. Number one is that during that time frame I mentioned, they really had the Delta variant. So all it really tells us about, practically speaking, is the protection against Delta. And we know that some of the other variants out there, the Beta and the Gamma, from Brazil, for example, might have more in the way of resistance to our immunity, whether that be vaccine or to natural infection. That's really how the Gamma variant made its name for itself, was by tearing through Manaus and other places in Brazil and reinfecting people that had been infected before. So it may be that the Delta is going to be an easier target for that sort of test and that sort of study than some of the other variants that are still out there lurking. It might be different. It also doesn't take into account what boosters are going to do to that effect. It may be that vaccine immunity wanes more quickly than natural immunity. And so we don't know how that's going to be affected. We already know that the immunity from the vaccine is in fact waning. We've seen that. That's really what's made the CDC and NIH have a bit of an about face about boosters in general. They've been saying for a long time, or no need to take boosters. It tends to hold up very well. But it turns out that these data and some other data that are coming out from other countries that were maybe ahead of us in the vaccine performance, such as Israel, that immunity is waning. And so if it wanes faster than natural immunity, that can account for some of this as well. So we need to look at that and see. And thirdly, it is an observational retrospective study. And I just mentioned that we're looking for tests and studies that are, that are blinded and prospective, and they try to remove all that bias. So there's some intrinsic biases that we have to be careful about in this study. For example, just to point out one, there was no systematic testing of people. We didn't test everybody in this study once a week in a programmatic style that would really pick up all the infection. So it could be that people that never bothered to get vaccinated before, the natural infection group, would not, unsurprisingly, would not have been as careful to go get tested again all the time if they had been exposed. So it may be that you were more likely to pick up those infections because those people in the vaccine group were more likely to go get tested at the proper time. So those sorts of things can really make some of these data a bit more murky. But safe to say that it was encouraging that there was fairly good resistance to infection just based on even past infection alone. But the one thing I would stress more than anything else is that it does not say, as many people are, that I've been infected, therefore I'm fine, I don't need to get vaccinated. I've got people in the ICU who've had clear past infections or who are dying. And so you get at least 2.3 times protection was in the CDC study out of Kentucky recently. This study does not contradict that at all. It was harder to get to the numbers in this study of how protected you are, but the message is clear from what we know. And that includes this study, that no matter where you are, no matter what your past situation, vaccinated or not, infected or not previously, your safest route is to get vaccinated now. And then you have to add on the overlay of the potential boosters that are going to be coming out too. It seems that immunity is waning somewhat, and it's less clear exactly when you need the booster, exactly what that protection is going to add to the protection that we had before that is waning. But it's increasingly clear that that's going to be helpful as well to add on to that vaccine immunity. But I think that's the biggest take-home point, is that this study does not say that you're fine with your natural immunity. It also says that you don't want to go out and get infected. I mean, you've even heard people say, well, that means I should go ahead and get the infection over with and provide that extra protection. It is completely illogical to say I'm going to go out and expose myself to the very risk that I'm trying to avoid by exposing myself to that risk. That is an illogical way to look at it. So certainly no one should try to get infected to gain protection against infection. And surprisingly, we even hear that.
Thank you. It seems a little counterintuitive, doesn't it?
These things are very difficult. I'll tell you, and it raises a point that I think is worth making. I was talking to Ahmad Omer, one of my partners today, who's one of the smarter guys I've ever met, and talk about the fact that these are very complicated pieces of information. We didn't even talk about T-cell immunity, which is maybe way more important than these antibodies that we're trying to measure and make sense out of. I'm a T-cell immunologist in HIV by training and research. It takes days to do some of those assays. You can't get a tabletop T-cell assay. So that's why we don't have as much data on those things. But it may be that, the more we look at antibody immunity, the less it's really correlating with things. And it may be that, T-cell immunity is more important after all. But we hear people all day say, I have researched this, or my spouse has researched this, and we think we don't need to take the vaccine. And I try to kindly point out to people that research is when you make a scientific hypothesis, you go out and you test it with experiments, and then you add to the information that is out there. That is what research is. You're gathering information, reading about this a bit is not research. It is just obtaining information that's already out there. And the sad reality is that you are very much at the mercy of the quality of information that you are consuming, whatever that is and wherever that is. So the average internet article is not necessarily great information. To make matters worse, the so-called confirmation bias is heavily at play as you are, as somebody might say, researching this, because people tend to read things that they already agree with in the first place. If your team wins the game, you want to go out and read every article you can about it. If they lose, you don't want to pick up the paper or the internet or anything and even hear about it. And that confirmation bias is very, very important as people read about these things. So it's important that you get information that is accurate and that really is research.
Hi, Dr. Threlkeld, can you hear me?
I can, Stacey. How are you?
Hey, good. Yeah, it's Stacey from Channel 3. I'm doing well, thanks. Hope you're doing well as well. I wanted to check with you. So I heard from my OBGYN that unfortunately a pregnant woman passed away from COVID-19 at Baptist. So I wanted to know if you could confirm that and if you knew anything about the circumstances surrounding her death.
I can't really speak to that at the moment because I think it was actually someone else that, if they were, I was not directly involved in that person's care, to my knowledge. So I can say that I have seen it before already, independent of any recent case. Certainly, in any cases, I wasn't seeking to say that it's very clear that getting a vaccine, whether you're trying to get pregnant or are pregnant, is a crucial thing for pregnant women to go with. Unfortunately, I'll even see some doctors still saying that, why don't you wait till your pregnancy is over? No, that is the wrong choice. I think the jury is in. There are good studies that show that death of mom, critical illness and ventilator treatment of mom, prematurity of birth of baby, death of baby even is significantly increased in those who develop COVID-19 infection. I have seen several pregnant women end up on the ventilator, and there's nothing as bad for new baby as a mom who is not getting oxygen to then deliver that oxygen as the sole source to the unborn child. So there have been large amounts of studies, hundreds of thousands of people pregnant who've received the vaccine, and there is no indication that there is any increase or any signal to suggest toxicity from that vaccine. So it's nothing more, I think, than a specific example of what we have seen in the larger population that includes pregnant and non-pregnant people, and that is that I've lost track of the number of people long ago that I have seen die of COVID-19. And I can give you a list of infectious disease colleagues around town that I've talked to, and to my knowledge, in talking to people, there has not been a single even hospitalization from a vaccine. Now, people get allergic reactions. They're generally dealt with very quickly and efficiently in the outpatient basis. Everywhere you go to get your vaccine is equipped to deal with those. But again, many people have died of COVID-19 that I've seen, and not a single, so much as a hospitalization from somebody from the vaccine. So this is nothing more than another example of the painful reality that. And I mentioned this yesterday when the county mayor and the head of the Shelby County Health Department were here at the hospital. It is increasingly the case as we look around the ICU and see only people who are unvaccinated in those ICUs and dying. The sad reality is it's becoming a choice. People are choosing not to be protected. And unfortunately, a small number of them pay for that choice with their very lives. We just urge people, plead with people to continue to get that vaccine, especially, as your question points out, pregnant women, because they pay a larger toll for these infections than other populations. They're up there with the populations of the morbidly obese, the elderly, the folks with immunosuppressed status, because pregnancy is an immunosuppressed status temporarily for immunologic reasons. Mom and baby are different immunologically. We don't want mom's immune system attacking baby's immune system. And so you're somewhat immunosuppressed, particularly in late stages of pregnancy. We saw this in influenza pandemic deaths in 1918. Advanced pregnancy folks were hit particularly hard in that time, and we're just seeing it again in this pandemic as well.
So I just want to confirm, like, I understood what you said. You said that you have seen several pregnant women end up on the ventilator, but in Baptist under your care, you have not seen any pregnant women die. Is that correct?
The reason I have a hard time answering the question is because I see people at the Women and Children's Hospital here, and I see them transferred here, and I've seen them transferred, younger ones downtown. I have been involved in the care of people who have died, but to my recollection, none of them have come to Baptist Memphis where I cared for them here and they died while pregnant. I don't recall that happening in this building, but again, I've seen them in other places and transferred them other places where it has happened.
And these are pregnant women, you're saying?
Yes, absolutely. Yeah, no, absolutely. And and we see quite well. I mean, regularly. It's still a small number of people, but we've seen several people who've, at the very least, had to have the baby delivered prematurely. And thankfully, in those situations, to my recollection, the baby has always done okay in the end. But that's a bad thing. In order to save mom to have to deliver babies prematurely, we've seen that happen on a number of occasions. And so these are bad situations. I mean, again, the jury is in. COVID in pregnancy is a bad thing. Vaccination for COVID in pregnancy is not a bad thing. There's no evidence. The American College of Obstetrics and Gynecology strongly recommend vaccination for COVID at any stage of pregnancy or trying to get pregnant. So does the Maternal Fetal Medicine Society. So does the CDC. So I think the data are pretty clear now about these things. Yet it remains, that and the fertility issue remain some of the most common objections that I hear about getting the vaccine. And like so many other situations, the very thing that's making people nervous about getting the vaccine should be the reason that drives them to the vaccine, because they should be a lot more afraid of what they're avoiding by getting that vaccine.
Okay, thank you.
You bet. Any other questions?
Hey, Doctor, can you hear me?
Yes, I can.
All right, it's Brandon with Channel 5. I had a quick question. We saw the numbers this morning, a record number of hospitalizations in Tennessee, record number of people statewide on ICU, and then Shelby County confirmed over 1,100 new cases this morning. First, are you surprised by those numbers here at the beginning of September? And what are your top concerns as we head into the fall?
Yeah, it's very, very complicated stuff because we see fits and starts in all directions. And so there are some encouraging things in our building. I mean, our number of hospitalized cases has gone down over the last week or so a bit, from 152 to down into the 130s, as we mentioned earlier. So that's cause for some hope that the worst could be at least upon us, if not behind us. So that is somewhat encouraging that the stream is not just continuing to go up, but that is not shared all over the state, as you point out. It's not even shared necessarily all over the vicinity of Memphis. So these hospitalization numbers are going to vary, and then the things that are concerning about it is that just because our hospitalizations aren't going up doesn't mean that deaths are not going to go up afterwards, because as we've seen this sort of unfortunate situation play out, cases go up, followed by hospitalizations a week or two later, followed by deaths. And the death curve is going to be more protracted this time, because the death curve the first time we saw this was in much more elderly populations where they did not survive hospitalizations as long. So we're seeing a lot younger people dying now, and they tend to survive for a lot longer time before they succumb to the infection. So unfortunately, some of these deaths are going to play out over weeks to come. So the numbers are complicated to interpret. I think the concerns that we have, as you mentioned, going into September, we're just getting school started, and we've all seen the data that a large number of people are being infected in the schools, much more than we saw the first time. We feared that schools would be transmission chambers, and it was a little bit better than what we had feared the first time. Actually, a lot better, in part because with masking and a separation of those students, it was a fairly safe thing in the classroom. Delta has changed that. And the fact that we have stepped back from our care in the behaviors in the classroom has changed also, I think, changes that. So we're seeing a lot more transmission. And that's just another factor that will then play out potentially in household. It's hard to isolate a 6-year-old in the household. They need care and they need parents to be around them and the like. And so, there's a lot, and we see that the Delta variant is much more contagious, and it's much less forgiving of a household contact. Previously, you could have a chance of isolating somebody in their room and not having everybody in the house get it. It's less common now. So a lot of these kids that have the infection are going to translate into unprotected, particularly adults getting the infection too. Some of those people are going to be at high risk. Some will land in the hospital, and a few, unfortunately, will die. So I think we might not have seen the last of that phenomenon. We may see more of that to come in the next few weeks as the school scenario plays out more fully. Also, as we move into colder weather, recall a summer ago, the question was asked, gosh, why didn't we thought that this virus was going to go away in the summer? And I think we made the response, well, maybe it did go away. It doesn't look like it, but maybe it really did. And sure enough, when things moved into the indoor weather situation, we saw a skyrocketing of cases. So we have to be very careful about that moving forward, particularly as people have let their guard down, behaviorally speaking. We might see more of that sort of thing as we move indoors and get closer together with indoor gatherings in the colder weather. So both of those are concerns, not to mention the other variants that are out there. I mentioned yesterday that we were celebrating victory even as the Delta variant was at our doorstep, before this surge happened. There's nothing quite at our doorstep right now, but there are other variants out there that could certainly cause us problems. And as more and more people get exposed to the virus, both in the form of the vaccine protection and in the natural infection vaccine protection, you're going to see more of an advantage for viruses that evade immunity, maybe even more so than those viruses that are very contagious, although a lot of the variants out there have both of those characteristics. So things like the Gamma variant might be the one that would step in that is more contagious, but it also is slipperier to our immune system and certainly has shown itself to be very good at reinfecting people even with natural immunity. So we may see some of that as well. So all those factors are out there. And as I like to say now, if nothing else, we've gained humility. We have made a living on underestimating this virus, every aspect of it in its behavior. And so I think we would be very foolish not to take it very seriously moving into the winter months ahead of us, and to take those precautions. We have now twice come up to the brink of sort of disastrous consequences as a city and community, the types of consequences that we in fact did see in New York over a year ago, that we've seen in Louisiana and some other places that just were beset by more cases of this disease than they could handle logistically. And we've marched fairly close up to that precipice on at least now 2 occasions. We hope we're now in a situation to be able to back away from it again. And we're just fortunate in this city because, as we've said many times, we have a lot of beds, hospital beds per capita in our city. So we've been fortunate, but we certainly have to be careful moving forward that we don't that we pay attention and that we don't give up on the behaviors that might again be necessary 3 months from now. And imagine how little interest and enthusiasm there would be if we were hit by another variant wave moving forward. It's all been a really sort of tragic circumstance, and unfortunately the death toll has been quite high.
Thank you. And another quick question on masks. There's still that debate out there, and I guess maybe it'll never go away. But there was the other day I was in a convenience store. There was a 62-year-old man who walked in unmasked, and he said he hadn't been vaccinated, and he said no virus is going to take him out. So, and then of course we see on Facebook people still debate about masks. So the question is, do masks work?
So, and just for my curiosity, that man you said was unvaccinated?
That's what he said. He was unvaccinated and didn't have a mask on.
Yeah.
You know.
Well, again, we could go on and on about the data that might contradict his impression about that. We certainly have seen a lot of people in their 60s, in fact, taken out by this virus. So, do masks work? I think yes, they work, but it's complex, and I think the best way for masks to protect us would be for both the infected person, who may be asymptomatic after all, and the person who's to be protected and is not infected. And we don't know who they are either, but the best protection is for both parties to be wearing the mask. And so probably more important for the person who is infected to have it, because they're going to be sneezing particles out of their mouth containing that virus. And the mask is going to have a little bit easier time catching those droplets in the material, maybe even than the mask of the uninfected person is going to have it keeping it from getting out, particularly in a non-N95 mask, which offers obviously significantly more protection. So are they perfect? Absolutely not. I've many times used the example, if you're sitting next to someone on an airplane, both of you having paper masks on, and one of you is heavily infected and contagious with COVID-19, you're in trouble, mask or not. But if you're 2 rows behind somebody who has a mask on, you're probably in good shape if they're infected. The objections to masks are many and varied. Many of them are inaccurate. They say they can suppress your own immune system. They say you can make your infection worse by holding the virus in. There's just none of those things hold any water at all. And then my favorite, I think I may have mentioned last week, is that, well, you know what? A virus is 1 micron in diameter, and the hole in your mask is 200 microns in diameter. So how in the world are we supposed to be infected or to be protected when that mask is not going to anywhere near keep that small particle from getting through it? And that would be a reasonable argument, except that it's not. Viruses don't travel all by themselves. They travel shrouded and protected by water droplets. The imagery is like thinking of human beings traveling 65 miles down an expressway without cars. That's just not what we see. You have to be protected in those circumstances, and viruses just don't make it in the environment by themselves. They have to have carriers, these water droplets. The water droplets are in fact much larger, and they get caught up fairly nicely in those masks. So I think there are a lot of objections out there to masks that don't hold water. Again, are they perfect? Absolutely not. And they shouldn't be held as a reason. If you're masked, that does not mean that you shouldn't get a vaccine. It does not mean that you should stay 1 foot from someone next to you for hours who's infected. No one parameter is perfect, or something that's going to protect you with any certainty. You have to use many layers of this. And again, you go back to the school analogy. If we look at schools before, those studies that showed that classroom learning was safe, well, those tests all did social distancing, and they all did mask utilization. They did both of those things. And so one without the other is incomplete. And it's like the old Swiss cheese analogy. If you get through one hole, there's not going to be a hole past that. The holes are interspersed in different areas. So you have to protect yourself, I think, in multiple layers here. We hope this will be over soon. And one reason that we may be peaking now is that just the combination of vaccine immunity, the combination of natural immunity, and the combination of increasing careful behavior, all three of those count. And all these things work together to protect us. But are masks effective? Yes. Are they perfect? Absolutely not. Should they be used in the absence of other behavioral and vaccination strategies? No.
Thank you.
Yeah. Any other questions?
Dr. Threlkeld, can you talk about home COVID tests and the accuracy of those, and if there are any that are dependable, which ones, and should people trust them?
Yeah, so that is important on a couple of levels. It also allows us to sort of, I think, really look at a very common fallacy that people use about testing. So basically, the closest thing we have to a gold standard, and it's not a gold standard, it'd be the molecular PCR test that you would get at a medical facility, office, hospital, or the like, where they actually swab your nose and do a fairly deep swab, and they actually look for RNA, the so-called PCR, polymerase chain reaction test. Those have the best sensitivity on the order of 80+% in finding those tests. Note that it is not 100%. If you go down to the rapid tests, they also use nucleic acid technology. They're much faster. You can get them in a few minutes at an office, 10 minutes, 15 minutes. And they are still very good, but have a little less sensitivity. They will miss a few more of those cases, closer in the 70% range and thereabouts. The home tests are a different type of technology. They use antigens. They actually look for the pieces of protein in the virus. And they have a lower sensitivity still. So it's important to remember that you can miss infection with these tests. There are data out there that even popular ones can be as low as 50% or lower in some circumstances. They've been criticized in some articles and data about that. So they're much more likely to be used as a screening sort of issue. You may need to do it multiple times. Having widely available antigen tests that are cheap at home, it's a great thing. You can test yourself every week for school. We talked about that largely throughout the entire pandemic, that it would be a good thing to do that. But you just have to realize that any one test from those is not going to be very definitive, because you will miss a substantial number of those cases. They're probably more problematic when you're asymptomatic and just screening yourself. They're more likely to catch it if you are highly symptomatic or symptomatic at all. If you're sick with it, you're probably putting out more virus and more viral proteins that are actually what that test is looking for. So it's more likely to be positive. So they are helpful if they are positive. And that brings me to the other part of it, that is they are not so helpful if they are, let me put it differently. If they are positive, they are helpful, but people are ignoring that anyway. So every day, seemingly, I talk to someone who says, well, I had one of those home tests and it was positive, but then I went and did a rapid test at a medical facility and it was negative, so I went to work or school or wherever. And that is a terrible mistake. These tests are very specific. They're 98, 99+% specific. Even the home antigen tests are very effective. If you go back to the original New England Journal of Medicine article on testing for COVID-19, there wasn't even any treatment of false positive. False positives are not impossible, but they are extremely rare. And it's a hard concept for people to look at positive predictive value and negative predictive value. And I will, at the risk of repeating myself, I think I've mentioned this before, but the analogy I give to people is that of a wildlife camera. If you hang a wildlife camera in the woods and you come back the next day and look at the overnight pictures and you have 20 pictures and picture number 17 has a deer on it and the other 19 do not, the answer to whether there are deer in the woods or not is yes, because one positive picture of a deer trumps all of the ones that say there weren't any. And then if you say, well, you know what, I'm going to go buy a better camera and I'm going to do it again tomorrow night, and you take a better camera and you take 10 more pictures and they are all negative for deer, you still have deer, because in COVID-19 testing, much like wildlife photography, a single picture with something in it that's positive is much more important and definitive than a number of things that are negative, because it's just much more likely to be real when you see it, and it's much more likely to miss it because they just don't see them all that often. So the important take-home point is that you can miss them. You don't count on them. If you really are symptomatic or need really to know, and you're not just screening, you're probably better off with one of the nucleic acid tests, even preferably the PCR.
Thank you.
Yeah, you bet. Time has kind of gone a bit long, but I was going to answer just a couple of the ones from the feed. And there were several people that answered. Cynthia Ramey, Angie Ledbetter, and others asked about how long should I wait between the flu vaccine and a booster. And since COVID boosters are the same as the old COVID vaccine, it's just a third one of them. It's a question that we'll be facing, particularly as we do boosters into the fall. As of yet, there are no good data that suggests that you shouldn't get them at the same time. When the COVID vaccine first came out, the idea from the CDC and the recommendation was to wait a couple of weeks before or after another different vaccine to take the COVID vaccine. That really was more a matter of just trying to make sure that the side effects were isolated and that we knew what we were dealing with in the way of COVID vaccine side effects, and we didn't confuse them with other vaccines. It did not really have anything to do with the fact that they might not be as effective on either front. So there's no data that suggests that you need to separate those, which is going to be, as I say, a very important question moving into, I think, the fall. As I say, several people asked that question. And we answered this one sort of. Tangi Green asked, should vaccinated people get tested for COVID antibodies before taking the booster shot? The answer, both officially from the CDC and conceptually, is no, because the antibodies that you are measuring may be random antibodies that are sticking to some part of the virus that doesn't put it out of business or neutralize it. So-called neutralizing antibodies are the ones that bind to the spot where the virus wants to attach. And those are the ones that put it out of business. And those are the important ones, but you can't tell on almost all the antibody level tests that you're doing which those antibodies are. So antibodies, again, have not been shown in any way to predict protection. They were never designed to. They were designed to see if you had been infected. They were not designed to show whether you're protected by their presence. And finally, Monica Green asked, should people that have been exposed still quarantine also? And that's, I think that's important because the CDC guidance on that has changed over time. Now, if you're fully vaccinated, you don't have to quarantine per se. You should still carefully wear your mask indoors. You should test again 5 to 7 days after that exposure to make sure that you didn't convert. And you should also be very careful for any symptoms that might or might not come, even if you get the infection, but you should be very careful to test for any symptoms along the way. So always consult the latest CDC guidance on that, because it's gotten a bit tedious in terms of whether you're vaccinated or not and what those exposures are. So thanks for those. Any other questions? Okay, thanks very much. Have a great weekend.
Thank you.